Good morning.
Morning.
Talk about.
Sign on yet? No? Well, we have some people that might be signing in.
Okay.
Yeah. So,
All righty. They'll be speaking up or something. If so, if you have any questions about the material presented, just speak up. It's just us. So we're good. So we're going to talk about bioethics as relates to society and especially healthcare bioethics. Okay, so specifically, the first general topic is going to be ethical considerations in what we would term public health. And public health is a concept, or we'll say it is a process by which communities or the state representing communities organizes certain endeavors to protect the public welfare, specifically the physical welfare. And nowadays are supervised by state organizations. In the past, they were more, we'll call them societal in origin. And several examples to show that public health as such is not such a new concept. The ancient Hebrews had a number of laws pertaining to segregation of people considered contagious, specifically leprosy. There's a number of laws dealing with, in the Old Testament, dealing with how lepers are not to be allowed to be in constant contact with other members of society. They were made to live apart. They were made to shout unclean whenever anyone came close to them, and so forth. They also had a number of hygiene, washing laws, and also a number of food regulations. They weren't allowed to eat just anything. The Romans were probably the greatest of the ancient engineers. They actually were able to bring water, clean, reliable water supplies to almost all of the urban centers through a series of aqueducts. And they had, in many of their cities, very advanced sewage systems, systems that were more advanced than anything that the Western world saw until the late 1800s again. It was literally almost 2 millennia before we had the same degree of sanitation as what Roman cities enjoyed. Public baths were very common in Roman cities. And in ancient China and Africa, there was a practice that was apparently discovered independently, which was inoculation for smallpox. Smallpox is a very deadly disease, mortality of about 30–40% historically. And someone figured out that if you took a little scab of a smallpox victim and actually drove it under the skin with a needle of a person who had never had smallpox, they would get smallpox but wouldn't get it as bad. They had a very low chance of dying, and they were immune from then on. That was inoculation, different from vaccination. And that was practiced actually into fairly modern times, into the 17 and early 1800s in the West as it spread. And then there were attempts at quarantining people, especially during the times of the plagues, especially the bubonic plague in medieval times. So there's some historical activity in the realm of public health, but in modern times, public health comes to the forefront because of urbanization. Large cities, as we would understand them, did not exist until the very late 1700s, early 1800s. Towns of over 10,000 were considered very big urban centers back in the late 18th century. Large cities didn't exist as we know them now. When people began to crowd into cities, the rates of diseases just skyrocketed. Transmissible diseases just went through the roof. And so to deal with them, a number of measures were put in place. At the same time, in the 1800s, a number of theories that are proven to be correct are developed about communicable diseases. No one knew anything about them. You knew that you could get sick if you were close to somebody, but exactly what was going on, the concept that there were things smaller than we could see that were causing these didn't exist before that. And when sanitation, waste disposal, inspections began to be commonplace, we started to see a significant drop in urban mortality. And that came along with the use of vaccination. Vaccination for smallpox was developed in the 1700s by a gentleman by the name of Jenner, who realized that milkmaids who were infected with a cowpox virus didn't get smallpox. So he began to inoculate people with the cowpox virus, and that's where we get the smallpox vaccine originally. At the same time, in the late 1800s, there was a huge movement led by Louis Pasteur to improve maternal health. Women would die in childbirth like 10% of the time, 15% mortality in childbirth. It was considered a health hazard to have a child. It was dangerous, statistically dangerous. And he pioneered a number of things to reduce that. So all of these things coming together in the late 1800s, early 1900s, foster an awareness of what we would term public health. What is, the well-being, especially in urban areas, and allow control of these diseases and subsequent mortality to really become an established fact. Okay. So tuberculosis and venereal diseases were quarantined in the early part of this last century, in the latter part of the 1800s, especially when TB became understood to be communicable. It was something you could get just from breathing the air of someone who was sick. They were coughing around you, you'd breathe little tiny droplets of infected material and you would get it. So people would actually be quarantined. And there are still laws in many states that allow non-compliant patients with TB to be jailed. They can actually be jailed. There's a state hospital here in Lantana where people who either have multi-drug resistant tuberculosis or have been shown to be repetitively non-compliant can actually be ordered by the court to reside while they get the treatment in very extreme cases. So the big breakthroughs have been with vaccination. Almost all of the childhood diseases that were associated with death or disability are now controllable with vaccination. That's the list. The smallpox being the first one, polio, tetanus, diphtheria, whooping cough, measles, mumps, pneumonia, meningitis, German measles, hepatitis, chickenpox. They all now have vaccines that are pretty effective. The only one that's an exception there is TB. The tuberculosis vaccine is reasonably effective. It is not used in this country for epidemiologic reasons, but it is used in the rest of the world. It's called the BCG. And it does reduce the number of TB cases significantly, but it isn't 100%. And the reasons they don't use it in this country is a little complicated, but it has to do with being able to screen people in case they turn positive on skin testing or blood testing. Anyway, so vaccination nowadays is able to prevent almost any communicable disease that is of importance, with a few exceptions. And before we talk about the vaccine issues that we have in this country now, we'd like to talk about what epidemics and pandemics are. By definition, an epidemic is an outbreak of a contagious disease that is involving a relatively defined geographical area. It may be a small area like a township or a city or a county or half of a state. It may be half a country, maybe a whole country. A pandemic is an epidemic that basically is either worldwide or involves so many parts of the world that it cannot be considered confined to a fixed geographical area. So it's basically a large-scale epidemic that is involving either all the world or much of the world. And an example, we're now exactly 100 years from the onset of the 3-year influenza pandemic of 1918 that is estimated to have killed 50 million people. 50 million, more than were killed or died as a result of the First World War. and occurred right on the heels of the First World War. And in fact, I had the opportunity, I've been in practice a long time, I had the opportunity to take care of a retired priest who was actually a seminarian in 1920 in Philadelphia when the flu struck through there. And he told me that they were like 1,800 people in the seminary. This was a huge seminary. There were a lot of priests in training there. That there were days that so many people died that they could not bury them in single graves.
That's the single flu that we call flu today.
Influenza.
Same thing.
Influenza.
Fever and headache.
Right, but this particular flu strain caused extreme reactions, extreme immunologic disorders, we'll call them, in human beings. The stories were that you would get sick in the morning, be desperately sick by noon or afternoon, and be dead the next day. That's how it was. It's like something out of a horror movie.
Yeah.
But he was a young man then. He remembered. He was probably, when I met him in the late 80s, he had to be in his late 80s, and he remembered there were very 4 or 5 seminarians a day for a few days in graves because there were just too many people sick, and nobody well enough to bury people in individual graves. Very, very dramatic. So vaccinations. We'd like now to focus on some of the ethical and legal considerations regarding vaccinations, because influenza does have a vaccine that is reasonably effective. Every year, the vaccine usually has 3 or sometimes 4 different strains that are anticipated to be the most common that winter, that is prepared usually in the spring or summer of the preceding flu season. And it is made available to the public usually in late summer, early fall. September, early October, it's available. It's been available now for a month and a half. And that, like other vaccines, are available to the public for, their protection. And in fact, most states, every state has laws requiring students at schools, at universities, and I want to say also in daycare, they have to have proof of vaccination before they can participate in those activities. But every state has a series of exemptions. All of them have exemptions if you are known or suspected to have intolerance or allergies to 1 or more vaccines. And allergic reactions to vaccines occur. They're very rare, but they do occur. There are kids get a vaccine and get these awful rashes or awful reactions and can't have that vaccine again, but they're very rare. Most states have. Hi, good morning. So most states have exemptions for religious objectors, people who think that it is against, God's will or whatever to get vaccinated. And in fact, 47 states allow parents sign a paper that says, I have religious objections. Many of those do not require that you cite what religion you belong to or what specific objection you have. You just have to say, I have religious objections. And actually 17 states have a so-called philosophical exemption, that you can actually say, I have just on general principle, my own, life ideas or life concept is that I shouldn't get vaccinated. So I'm not. And you can sign a paper and are not required to have your child vaccinated, and they can still participate in activities and so forth. In reality, there's only a couple of religions, and not everyone in those religions, who have some objection to vaccination, some Christian Scientists and some Amish, but it isn't, even in those religions, there isn't very strongly worded or written in stone objections to vaccines. It really more is the concept or the reluctance to have vaccination. But again, most states are extremely liberal in allowing children not to be vaccinated if the parents have serious objections or not serious objections. Florida is one of them. Florida, parent can say, I don't want my child vaccinated because I have some issue with it, whatever. They don't have to specify what issue.
You know what, I don't think I think in the protocol system, you have to take that vaccination. I don't think that there's too much leeway.
It may be a rule of the Catholic school system, but in the state of Florida, you cannot mandate a child to be vaccinated. You cannot exclude a child from participation in at least public schools. If the parent signs the paper, it's a waiver, and you can get it online. And that's the law. You don't even have to say I belong to a religion. You say I have religious views that don't allow me to vaccinate my child, and that's it. You're off the hook, so to speak.
I'm not sure if it's a rule in Catholic school, because I really don't get into that side of it. So, what if a child, a parent in the public school system refuses to sign off on it?
They have to sign the paper.
Okay, yeah. So they sign off on it, so that my child will not take a vaccination.
Yeah, the law is clear. You cannot send a child to public school or to daycare or to any university without vaccination. You have to have it, except if you go the route of exempting them for religious or medical, or in a few states, philosophical grounds. Okay. But it's very simple. You print up the paper, you sign it, and that's it. You're off the hook as far as the law is concerned. So the law is very strict, at least on paper, except that it has this loophole that allows you to get through it. And that's the way most of the nation is like that, actually. Okay, so this is the consequence of not vaccinating. These are relatively recent outbreaks. In Pennsylvania, in 2013, there was a measles outbreak. Now, measles, you don't think of measles as being really a catastrophic disease, but 1 out of 100 children who gets measles will end up with cerebral damage. And 1 out of 50 will end up with either heart or lung damage that will be serious. So it can be, for most people, an unhappy experience, but no major consequences. For a modest minority, small minority, it can be life-changing. That's a big deal. A year later in California, there were, the Pennsylvania outbreak had 1,200 individuals affected with measles. In California, the year later, there were 125 cases that spread into 8 states. 8 states had their public health systems going crazy, trying to track down, because measles is a very communicable disease.
I remember that. Yeah. I remember that being in the news.
When they tracked down everybody, they found that 2/3 of the children who got measles in that outbreak had been intentionally not vaccinated. Parents had made the intentional decision not to vaccinate. These weren't all like illegal immigrants who didn't have access to the health. So these were 2/3 of them were people who had access to the vaccine, didn't want to have their children vaccinated. So it is estimated that between 2% and 4% of the children in California, and the same applies to Florida, these are estimates, are not vaccinated at all. 2 to 4% are not vaccinated at all.
Student that just
I need to talk louder?
Can you try again?
Sure. Okay. So we'll go back to where we were just a second ago.
Hi, Doctor. Good morning. This is Father Machado from the Diocese of St. Petersburg. Sorry to interrupt. The thing is that I did not hear you, but now I hear you. Now I have audio.
Father, thank you.
Very welcome. It's a pleasure to be here.
Okay, so we're going to move on this now. We'll be going back to the slideshow in just a second.
Sorry. Was it this one?
Yep. Okay, great. So we were talking, Father, about the some episodes of diseases that are preventable by vaccination having caused minor outbreaks, and the outbreaks were largely propagated by children that had not been vaccinated. And the comment was that the estimates, both in California and in Florida and many other parts of the country, is that somewhere between 2 and 4% of children are not vaccinated at all, many out of conscious decisions by the parents. And we were mentioning that there was an outbreak of measles in California 4 years ago, where over 100 cases were reported. The outbreak spread into 8 states. And it was found subsequently that 2/3 of the children involved in the outbreaks, in that outbreak, were not vaccinated intentionally. In other words, they had the access to the vaccines. The parents made a decision consciously not to vaccinate. The consequence of that from an epidemiologic point of view, if we had a population of unvaccinated children, in other words, if the population of children in any given state were not vaccinated at all, such an outbreak would have affected thousands upon thousands of kids. So this issue of having children not vaccinated has serious public health implications, not only for the unvaccinated children, but for everybody, because it does cause a lot of disruption in terms of schools and so forth. So this is a list of reportable diseases, meaning that if a doctor has a case of that, they have to report it to the public health system. You see that there's like 100 diseases there, just to give you some idea. All right, so we'll talk briefly now about sexually transmitted diseases, because there's a number of ethical issues involved in this that tie into the law, mainly having to do with notification of partners. Specifically, what happens if you don't notify and or treat a partner of someone who has an active disease? Well, the likelihood is that if they're not infected, they could get infected and then just bounce the disease back to the treated partner again. So some of these, especially chlamydial infections in women, are known to be the major causes of sterility. They will scar the fallopian tubes and make it impossible for a woman to have a normal intrauterine pregnancy. They can cause serious infections in and of themselves that will need surgery. So it's a big deal. And it's estimated that the public health system is effective at contacting only 1 out of 5 partners of people who show up to their clinics for sexually transmitted diseases, meaning that they have maybe a 1 in 5 treatment success for partners. They're successful in contacting partners about half the time. And this is a big deal because many states have specific confidentiality clauses in their laws that do not either require or in some cases do not allow the public health system or any physician or clinician to contact a partner without the patient's consent. In other words, if a patient comes to a doctor and says, I have this, or I think I have a sexually transmitted disease, and the doctor says, yes, you do, does the test and so forth, the doctor has to get consent from the patient to reach out to the partner or partners and say, this person, my patient, has been diagnosed with this. You probably have been exposed. You need to be checked and treated if you have the condition also. If the patient of the initial patient does not allow that, the doctor has no recourse.
What argument do they use to support that reasoning, that logic?
Patient confidentiality. Patient confidentiality. That's what is used. A few states mandated this. See, this is, we'll call it the drawback of living in a federal government system. The states design most of their laws. Criminal laws, civil laws, administrative law is usually at a state level, except things that pertain to the federal government, like the post office and things like that. But medical legal issues are settled at state levels across the country, and they vary all over the place. Like New York, for example, has a law that requires doctors to notify partners. You're required by law to do it. But Florida, if you try to do that, you could be sued for breach of patient confidentiality.
So the common good is about privacy. It's not about the overall care.
Well, I mean, that's why this is such a big deal, because it pits a legal issue with a moral issue. Morally, if I know that someone has a potentially dangerous disease, syphilis can cause permanent mental and neurological damage. Gonorrhea can cause major permanent damage to men and women's reproductive systems. And it can kill also in rare cases. If I have a patient comes to me with gonorrhea, I know they have a contact, and I say I'm morally obligated to tell that person, I could be sued in the state of Florida for breach of confidentiality. So it is an issue. Some states get around this, and this is done in Florida by giving the initial patient a treatment package of whatever antibiotic is appropriate and saying, give this to your partner. And hoping that the partner, because you don't want to tell, a lot of people don't want to tell their partner, say, I have gonorrhea, or I have chlamydia, I have syphilis, or, it's awkward to say the least sometimes. But they're called expedited partner treatment. You don't see the patient. You don't know what the patient looks like. You're giving the person who presented to you a treatment program for that patient, which brings that has a lot of liability too. But it is a compromise between not doing anything if the patient who is your initial contact refuses to allow you to notify the partner or partners. So it's some compromise to try and get people treated if they have a contagious disease.
So what's the ground for this patient confidentiality rights instead of supplying the greatest good for the greatest number?
That's how the law reads in Florida. The law reads that a doctor is obligated to preserve a patient's confidentiality, information, and is not allowed to divulge it without that person's consent to anybody, unless under legal obligation by a subpoena or a court order.
So the doctor could go for that. Let's say the patient has diagnosed patient with HIV.
Mm-hmm.
Right? Probably that's the wrong one.
No, that's a good example, actually.
Right. And so you can go basically above the patient and go to the judge to get an order issued.
I could go. It usually works the other way. Usually there's some problem that there is some litigation involving something, and then you are called as a witness and you have to provide your records. Those are the circumstances. So realistically, no clinician, whether it's a nurse practitioner or a physician assistant or a doctor, nobody has great inclination to go to court for anything. As a rule, it's like you really the legal system is a nightmare in many respects. This is not a simple thing to do. And you can counsel someone and saying, look, think about what you're saying, think about what you're doing, But the reality is that, you know, somebody has a boyfriend or a girlfriend and don't want them to know. HIV is actually the best example, because HIV up until the very early 90s, from the mid 80s to like 93 or 94, HIV was a fatal disease in many cases. And it is not, it is obviously communicable, but it isn't communicable on just casual contact. There are people that have been having relations with other people that are HIV positive and they themselves are not. But eventually you'll get it if you have enough contact, I guess. And this was a big deal in the early 90s. You couldn't tell the partners of somebody that they were HIV positive.
Doctor, talking about an example, I'm assuming then that as a physician, if you encounter a situation like this, you might have to involve an ethics consultant from the bioethics committee of the hospital, the healthcare institution, to help solve the situation and mediate, and eventually even involve the legal department to bring it to court. Otherwise, the damage will be.
If they're inpatients, yes.
If they're inpatient.
If they're in the hospital, but a person that's not hospitalized, there's no mechanism for bringing a hospital's resources to bear on that case. You can involve the public health service and say, look, I have this problem. What are my options? Or you can refer the person to the public health service. They're used to dealing with this, and they have probably a little bit, they have a lot more experience than most clinicians. There are doctors that specialize in HIV that, because of the nature of their specialty, they also see with more frequency sexually transmitted diseases of other types that also have facility in dealing with this. But the short and long of it is that, at least in Florida and many other states, you're stuck with that confidentiality situation. You face a serious lawsuit. There was a lawsuit here in Miami many years ago, and I want to say in the late 80s or early 90s, specifically because of an HIV case. A doctor was sued because family members found out that someone was HIV positive, and he lost a lawsuit. He had to settle. Yeah, it's a big deal. So at least in Florida, it's a problem. Other states have a little bit, or actually mandate, as we mentioned. So specifically about HIV, there are more than 1 million people in this country that are HIV positive. Usually, if you detect the infection within the first few months or year or so, you can prevent the immune system from being irreversibly damaged. So it goes from being a fatal disease to a chronic condition that is relatively easily managed now. Many good drugs for it. We do have the same issue that we talked about, especially notifying partners. I'm sorry?
I'm looking at number 3.
Yeah.
I can't get over that.
Yeah. Yeah. And it's like I say, yeah. In New York State, I am not only allowed, I am obligated to tell a partner or partners if someone has HIV. I have to do it by law. In Florida, I get sued if I do it. So
you have to fly the patient to Georgia and say, listen.
Well, it is, yeah. So you see where we're at there. There's not a lot of consistency. By the way, this just came out about a month ago. There is now, the FDA just approved a treatment of an HIV drug. It's a combination drug for prevention of HIV. In other words, people who are not sure if their partners are positive can take this medicine preventatively. It's the first ever preventive HIV medication approved for this.
Doctor, HIV is no longer fatal. It could be treated, but it cannot be cured.
Okay, that's a good question. The way that people see whether the HIV infection is under control is by measuring the number of viral particles in the blood. So they draw the blood and they have ways of detecting active viral particles. If there are no active viral particles, that person, A, is not contagious, okay, B, cannot likely have progression of disease because there's no virus propagation. The virus destroys different types of cells, specifically immune cells, but it attacks other parts of the body. It attacks some brain cells. It attacks parts of the GI tract. The problem is that the virus is also incorporated, its own viral RNA is incorporated into the DNA of the human genome, and it lives there. And it can stay there, and no one can tell that it's there. It may not be able to replicate, but you have white cells in your body that are carrying that virus around, and these are long-lived cells. They live years and years and years. So no one knows. There is some evidence that if you suppress the condition long enough, people may go for months and even years without re-expressing the virus, meaning that you can't say they don't have the virus infection. They have the infection, but it's just not multiplying again, even off of treatment. There's not been enough time, I think, to know for sure if that's going to be true or not in the long term. In other words, whether someone can really be totally cured of the disease having had it, of the infection, but certainly you can have no disease from it. You have evidence of having infection, but you have no disease. It's not doing anything, if that makes sense. Nor is it transmissible.
We still have the virus within the genome.
The likelihood is that you have the virus. The virus hides in like bone cells. It hides in white cells. It hides in cells in the brain. Yeah.
You know, when you first came out, there were many explanations as to the origin of this. Have you ever been able to determine the origin of this virus?
It seems to have been mutated from a simian virus in Africa. The first people known to be infected with it were serologically blood stored from people who died of strange conditions from the late 1950s. But it actually spread out into the Western world. In all likelihood, it spread first into the homosexual, into the male gay community, and from there, more or less concomitantly, into IV using people, and then with lesser degree but still significant penetration into heterosexual community. In the very first years of HIV, there were 4 sets of people that got it: people from Haiti, people who were IV drug abusers, people who were homosexuals, and people who had required a lot of transfusions, especially hemophiliacs, who required special plasma transfusions for clotting factors they didn't have, and the HIV virus was being spread through there. Yeah. Okay, so we move on to talk about a little bit about addiction and substance abuse in relation to public health. Alcohol. It's amazing. $250 billion of cost to society in terms of hospitalizations, lost work time, premature disability, premature death. Huge burden on society. And you can sort of get some sense as to why people were so keen on temperance back in the early part of the 1900s, to the point where actually alcohol production and consumption commercially was banned during Prohibition for about 8 years or 10 years, something like that. Huge cost. People would get, men would go drinking and go home and beat up their wives. That was a common thing in the early 1900s, very common. And it still is a common problem. Alcohol-related fatalities still top drug-related fatalities, especially driving accidents. Still the leading cause of motor vehicle fatality. Followed closely, however, by narcotics, cocaine, amphetamines, and other more modern designer type drugs. Those are estimates from a few years ago. Yeah, opiates have received a lot of attention lately. The only thing I want to say about opiates that you should be aware of is that people who know about this say when they talk about opiate addiction is that it's one of the hardest addictions to detect. People who drink too much come to work a lot of times with, you know, their eyes are red, they're all disheveled, you know, their hands shake a little bit. You know, people who have alcohol issues sometimes are not hard to pick up. Same with people who are using amphetamines. They're often jittery, nervous. They have, it's obvious to people that, hey, you know, like this person's a little too wired, so to speak. Cocaine has a type of pattern of behavior that is also, people who know it can pick it up quickly. But people who are very good at addiction have trouble picking up narcotic addicts, and they function perfectly fine or apparently fine for decades and decades without a problem. Rush Limbaugh, I think, is a really prominent example. This man was popping more than a dozen, I think it was oxycodone, I can't remember if it's hydrocodone, one of the major narcotics, habitually for back pain for a decade and a half before he got to medical attention. So it's very hard. Opiate addiction and can be fatal, but it is pernicious mainly because it's hard to detect. It doesn't necessarily impair people the way that other things impair them. But anyway, the cost is staggering. 10,000 deaths a year in 2014 from motor vehicle accidents, and 60% of people who are arrested have positive drug tests or alcohol tests. 60% of people who are arrested by the police end up with positive toxicologies of something. It is estimated that 12% of children have one or both parents with an alcohol or drug addiction problem. It's a big deal. And it's estimated over 23 million people in this country with some sort of dependence issues 10 years ago. So the number's probably higher now. It's a widespread problem. And for most people, especially alcohol, and to a significant degree, narcotics and other drugs, the cure rate is pretty good. It's known that there are treatment programs that work, but what it requires is literally a boot camp, we'll call it, where you are isolated from your normal activities. You go to a place that usually is some degree of resort-like environment where you have people who are trained in addiction, who are working with you constantly. It's almost like a brainwashing, like a prolonged brainwashing session where you are drilled and you are made to realize that you're killing yourself. The cure rate is about 2/3 to 3/4, so it's pretty good, all things considered. But you're talking about 3 months cooped up, not working, not doing anything.
Actually, we started off young Ghana many years ago in improvement and initial drugs. And they treated us all by hand. The Arabian hospital is across the street.
Mm-hmm.
I forget what the name of that place is.
Mm-hmm.
And I watched her that whole process. I go there every other day or so. It was
So you got a chance to see how it actually worked.
yes, she was a very close friend of my daughter too, so that's why I'm appointed.
And how did she do?
She's doing fantastic right now.
Okay.
She overcame it. She never got and this happened to her when she probably was 20, 22 years old.
One other thing I should mention about narcotics that people who deal with addiction mention, I think it's a good thing to know, especially if you deal with the public, is that you can get addicted on narcotics almost instantly. There have been young people who have overdosed and died on narcotics, and when they traced back when they first got on it, it was something no worse than being treated with hydrocodone or oxycodone following a root canal. they'd never been exposed to narcotics before, began taking it. They say, hey, I feel really good. It makes you feel peaceful. It makes you feel good. It takes a lot of anxiety away. And before you know it, this is part of your life. So, so there are, and actually many professions, the medical profession and the nursing profession, have specific programs in place for doctors and nurses and clinicians who are addicted or have substance issues that work, and they're confidential, but it's a big deal. And the big deal, you can imagine what an average person on an average income would have to do to be able to pay for a $50,000-$60,000 program. That'll bankrupt many people. It worked most of the time, but it's like, and you see it's the industry of rehab is actually a multi-billion-dollar industry in this country. It's $35 billion industry. Okay, there are 14,000 credentialed rehab facilities in the nation, ranging from 2 and 3 people, small settings, to settings that house 100 people at a time. Is very big.
So what happens to those who don't have that kind of?
They don't do well. They don't do well. Getting off of most substances, with the exception of alcohol, which has a different kind of situation. Heroin, all the narcotics, all the opiates, cocaine, very addictive drug. It's very difficult without this kind of supervised setting. The supervised setting is really that kind of take you out of your environment for a long period of time. 3 months is a long time. That works better than anything else. Better than anything else. But it's a problem. And actually the question comes up, and this is a societal, ethical, financial issue. Isn't it cheaper to get someone into a program for 3 months that costs $50,000 than to send them to jail for 2 years?
That's true.
Because that person, many people who are narcotic and cocaine addicts are stealing to support their habit. So they end up in jail sooner or later. Isn't it cheaper to get them, on the right path, but who's going to pay for it? That's an issue. Taxpayers not going to pay for that. How long a politician would last if they stand up and say, I want everybody, paying an extra 1% tax on their property tax or whatever, or sales tax, so we can fund this program for people who can't afford, narcotic. That they'll be kicked out of office the next cycle, guaranteed. So this is a this is a situation. It works, but it's a situation. Okay, so let me just one other point I wanted to make about this. Many substance, I would say maybe 90% of substance abuse occurs with the knowledge and sometimes outright facilitation of close family members or friends. Usually people who are in this kind of situation, somebody knows about it. Somebody knows about it.
In my case, they do.
Almost always, and there's people, family members, friends, significant others, all often will try to move it along and they're not able, they don't have the wherewithal, they don't understand, they don't to confront it, and oftentimes pathological responses occur that actually facilitate this going on and not getting treated.
My case is though Jamaican saying that applies with what we see them to do. Yes, you witness these things out.
Yeah. Okay. So that's it. Briefly, we'll talk about our healthcare system and ethical issues relating to our healthcare system. there's all sorts of issues with healthcare here in this country. Trust me, I'm unhappily aware of most of them. We have really good acute healthcare. There's nowhere else in the world where you can get really quick attention for an acute, life-threatening emergency almost anywhere in the country. Anywhere that isn't, you know, that has cell phone communication, you'll have a hospital with a CT scanner. If you fall and clunk your head and you have bleeding in your brain, you can get that diagnosed almost immediately anywhere in the nation. The Canadian system, by contrast, is set up in a tiered system. None of the primary hospitals in Canada have even a plain CT scanner. And there's probably 100 CT scanners in Dade County. I'm not kidding. The large hospitals all have 6 or 7 CT scanners. You know, a big hospital. And
you want us to adopt the Canadian method, right?
well, no, I'm just saying that we're talking about acute care.
Yeah.
Someone comes into the ER, and by law, there are very strict laws in this country about refusing health care to people in the ER. You cannot. A hospital will have the world's largest fine if they do anything shady about that. You have to take care of everybody that goes into the ER. Documented, not documented, it's insurance, non-insurance, everybody gets treated more or less the same. The problem is we cannot do the same for people who need outpatient treatment. Our outpatient system, if you look at it as a general system, really has problems. Very inconsistent, it's dependent on insurance, and you can have one insurance that one doctor will see you for that, but you won't see you for another. Some facilities work with some insurances, even hospitals for outpatient work don't work with all insurances. And it gets to the point that you have to just ask, is healthcare a right? Is it a right of every citizen to have a certain basic level of healthcare? As opposed to, is it a privilege or a commodity? Historically, when medicine wasn't very advanced and was semi-charlatan-like, and that wasn't that long ago, healthcare was really more of a commodity. If you could afford a really high-powered doctor, he may not help you because he didn't know much anyway, but that was the way it is. Now that the concept of availability and efficacy of medicine is pretty universal, everyone's going to say, well, if I can get chemotherapy here, why shouldn't everybody get chemotherapy?
Dr. Leodon, to the word right, what's the right? Let's say everybody has the right to basic health care. How far you extend everybody to? Does it include? You see, that's a whole different issue here.
This is healthcare right now is in this country is partly privatized, partly publicly subsidized. There are, like the VA system, fully government run healthcare systems. The public health is another government run. The public health service runs facilities for communicable diseases in big cities and in general medical clinics out in underserved areas and rural areas. So there's all sorts of, this has not evolved in a centrally guided way, which may or may not be bad. I'm not saying, I'm not advocating by any means for one way or the other. I'm just saying what we have right now is a system that has a lot of gaps.
Right.
Has a lot of gaps.
Possibly still the best system in the world. How do we make it better?
Yeah. Yeah, I would understand it so, all things considered, but it has a lot of issues. It has a lot of issues. And these are some of the issues. All right, so by law, in almost every other civilized country in the world, medicines cannot exceed certain price. The government says, okay, you'd have to take this medicine for arthritis. Well, we know that this medicine costs X amount. We will let the pharmaceutical company charge 25% more than its costs. And that's it. You know that whatever pharmacy in that nation you go to, that medicine is going to have that cost. And that cost is usually a little bit higher than the real cost, but it isn't 5 times higher. except in this country. In this country, we pay 2, 3, 4 times more for a simple, for many medicines that can be in Mexico or Canada or the UK, purchased for much less. Same medicine, same manufacturer, sometimes the same manufacturing facility. Okay. This nation, if I can put it this way, subsidizes pharmaceutical research for the rest of the world. Think about that. The American consumer pays for the bulk of pharmaceutical research for the rest of the world, because that's what we're saying here. That's what we're saying here. The bulk of pharmacies' profits come from this nation, and that helps fund their research. So we are subsidizing the rest of the world's pharmaceutical research and the rest of the world's, if you want to look at it that way, the rest of the world's pharmacy prices. And that to me seems very unfair.
That's the reason why I can sell it cheaper than we can sell it here.
All I'm saying is it doesn't seem right to me. I don't know what the solution is. It doesn't seem right. It doesn't seem right. All right. The other issues that affect care here in this country is that we have really unintended consequences of what were thought to be good laws or good regulations regarding documentation and regarding compliance with regulations. Just in private practice, I will tell you that the regulatory requirements sometimes are extremely burdensome. It's not just a matter of paying for a license, it's a matter of having to make the medical record in a certain way, having a computer system that does it in a certain way, and it becomes so time burdensome that doctors are often either having to hire a person to do that, which raises their costs, or basically, having to opt out of electronic medical records altogether and take the financial penalty that the government imposes, because the government imposes financial penalties on physicians who do not do things a certain way in terms of the medical record. So all sorts of things make practicing on your own a little bit more difficult. And at the same time, there are a lot of underserved populations. A lot of people, even after the reforms of the Affordable Care Act, a lot of people without insurance. And it's important to understand that the Affordable Care Act basically provided for many people what we would term catastrophic insurance. If your costs exceeded $5,000 in a year, then it would cover, but you were responsible for the first $5,000. Which for many people, what they need is just, they're healthy, they need, if they have a cold, they have a sprained ankle, they have a fracture, they have a gallbladder that needs removal, simple things, that's what they need, and that's what still isn't being provided effectively. Okay, so the other thing that we're talking about right now at the end is end-of-life issues. This country is burdened more than others by problems sorting out end of life. And if you are a deacon, do you do a lot of hospital work? Do you visit people in the hospital some? Okay. So you will undoubtedly see, if you go to critical care, people that look like they're going nowhere, that have been sick, maybe on a ventilator for days and days and things. And we'll talk about that. Basically, there's still a lot of uncertainty as to what's going to happen with the healthcare system. There is this last year a lot of push for a single payer system. Seeing how they play out in other places, I'm not sure that's the best solution, I think. But I'm not sure that there's any good solution, and I certainly am not one to hold out anything as better than anything else. I think it's a problem. There's so many issues, and this nation, as you know, is a nation of interests. The American Hospital Association, pharmaceutical industry, the health insurance industry are all very powerful lobbyists. In that pecking order, the American Medical Association is at the bottom, but they also have some voice in all of this. So there's a lot of pulling and tugging in different ways. We don't know what's going to happen. All right, so let's talk really briefly about some end-of-life issues. And first, address the concept of what is called medical futility. Futile means something that is of no purpose, will have no desired benefit or result, that you can do something. It's like scooping water out of the ocean and trying to drain the ocean dry with a bucket. It's futile. So in medical terms, interventions of any kind, whether they're surgical procedures, medical procedures, using particular medications, anything that is unlikely to produce a significant benefit to a patient would be understood to be futile. And there's different ways of classifying medical futility. Two types that are commonly cited are quantitative futility, where the likelihood of any benefit from an intervention is very low. In other words, I'll do something, but I'm not going to really get the person better. And then there's qualitative futility, where what I do may benefit, but the result, okay, the end result, what the patient's going to end up with, really is not going to be very good. And that in the former category would be someone who I know has, for example, a widespread metastatic cancer. And they come in with respiratory failure, and I know that the way they're looking, they have about a week to live. If they don't get put on a ventilator, they'll probably die in 24 hours. If I put them on the ventilator, they'll die in a week. Putting them on a ventilator is not going to provide any benefit to them. They're not going to get them better. I'm just going to make their dying process longer. So that would be
an extraordinary measure of life support.
that's life support. That would in Catholic terminology, that would be considered extraordinary. So life support may be ordinary or extraordinary depending on the circumstances. For example, if you have to anesthetize someone very deeply for very delicate neurosurgery, you have to put them on a ventilator because you've anesthetized them so much they won't breathe. So that machine is part of what would be ordinary procedure, because otherwise the person will die in the procedure. But in the case of someone who's got widespread lung cancer or whatever kind of cancer, who's going to die no matter what, all you're doing is prolonging the dying process, and then it becomes, then that would be understood in that terminology to be extraordinary. So the other futility, qualitative futility, would be where a person comes in with a massive stroke. That person has lost more than half their brain, will not recognize family members, will not walk, will not speak, will not be able to swallow on their own, will be left vegetative. They'll have a period of time in the first 3 days where the swelling in the brain will be so great that they will not breathe on their own and will likely pass away, will likely die, unless we put them on a ventilator and keep them alive those 3 or 4 days. And then when the brain swelling goes away, their respiratory centers are more normal, they will be able to breathe on their own, and we'll take the ventilator out, but they will be left in a vegetative state. So the intervention was successful in keeping them alive. The end result is really bad. And most people, would not want to be that way. Many people, anyway, would not want to be that way. So those are two ways of looking at futility.
Instead of using a ventilator, if you install a respirator without making a difference.
What's the difference in your mind between a respirator and a ventilator?
The ventilator, I think, is more when the machine is doing the function of the lungs.
And a respirator?
It helps the lungs,
But
it does not do the function 100%.
Okay.
Like,
Okay, so all right, in medical terms, when when we talk about respirators and ventilators, to us, they're synonymous. There are machines that are called BiPAP machines that don't, and okay, so artificial support in terms of respirators are defined, at least in this country, as having a tube either in your nose to your trachea or in your mouth to your trachea, or a tracheostomy that's connected. In other words, that tube seals the airway and allows air to go in and out only through that tube. So that, at that point, we consider it artificial life support. So these machines, whether we call them ventilators or respiratory or respirators, do that, do artificial life support. BiPAP machines can be ventilators, but they don't require intubation. It really, for artificial support, we consider, even though we consider intubation to be the criteria for that. If we put someone with a mask, a tight-fitting mask over their face, and connect that to a breathing machine, that's not considered artificial support for our purposes, at least in medical terminology, if that makes sense. Most people who are in the circumstances I described to you don't do well with that. You have to be kind of awake to be able to keep your airway open for the machine to breathe. If you don't have a tube in, the tube actually keeps the airway open, in addition to allowing the air to move in and out exclusively into the lungs. So we would, most people are hard to manage medically if they're really, really sick. If they're comatose, you can't really manage someone on anything other than an intubated situation. Does that make sense? Okay. So let's look a little bit at the cost of fetal care. There's a 2005 article where they estimated that 40 to 60% of care in the ICU was fetal. And that was based on specific interventions on anybody. In other words, it didn't mean that 40 to 60% of patients in the unit were hopeless. It meant that there were, of all the interventions done, about half were thought to be in circumstances where the intervention really was not going to make a big impact. It's extremely costly. It's estimated to be about 16% of the annual budget for medical care spent in this country in the last 60 days of patients' lives. Okay. And the CMS has statistics that Medicare spending, not all insurance spending, but Medicare spending for the last year of a person's life is 25%. In other words, a quarter of all Medicare spending, inpatient and outpatient, goes to people in the last year of their life. A quarter of all Medicare spending. Gives you an idea. And much of that is taken up in the ICU and critical care. I thought this was a phenomenon associated with this country. This is probably the best article actually looking at how much money is involved here. This is 5 years ago. This was published, I think, in the JAMA. UCLA Medical Center, one of their hospitals, they have several hospitals. One of their hospitals has 5 different critical care units, did a prospective study. They were actually looking at this with over 1,100 patients, about 15 doctors involved. And the doctors took a survey. And the survey basically said, at what point on any given patient are you engaging in fetal care? It was somewhat subjective, obviously, but these are clinicians that do critical care. So they, at the end of the study period, which was 3 months long, they found that about 20% of their patients had had fetal care at some point in their ICU stay. It ended up with 464 fetal treatment days, and based on charges, hospitals know that they're going to get a certain percent of what they charge back in terms of reimbursement. Usually it's like 20%, 25%, 30%. So historically, that's what it costs the insurance companies to have these people taken care of. So they use that same proportion, and they came up with a cost of $2.6 million for 5 ICUs in 1 hospital in 3 months of fetal care. And they validated this to some degree because 2/3 of the patients that were engaged in fetal care died while they were in the hospital. And of the rest, at 6 months, 85% were dead. In other words, of the total people who were thought to have entered a fetal situation, 85% were dead at 6 months, and the remaining 15% were totally incapacitated on ventilators or otherwise totally unable to do anything.
The issue on this is, let's say then, and I'm just talking on the turn, speaking on the turn, which would be say something like the ethics committee would take a look at this, and then the relatives of the patient that you are deciding on will call you the dead boy. But I see, you know,
Okay, but
there's evidence of this.
right. But let's look at it this way. Who is better able to judge when someone is in a situation where anything you do is not going to make a difference?
I would agree with you more
than the clinicians who deal with this day in, day out. Who's better able to judge?
Absolutely. Absolutely. But this is
So the problem is that these things occur in settings where there's very charged emotional situation. These are people that are dying, and they have relatives that have to make decisions who may never have had to make decisions before, and they have all sorts of issues, and they have no medical background, and we're all taught, because we see it on TV, the miracles of modern medicine, that we can get everything better. And it just and plus, I'll speak quite frankly, a lot of people that aren't playing with a full deck out there. A lot. You'd be surprised how many. Well, you wouldn't be surprised if you're a deacon. You deal with people in general, but I'll tell you right off, I'd say a good 10% of the folks we deal with in the hospital, family members, you're not sick people, but they're relatives of people, have some serious issues with regards to understanding things. The ability to accept that someone's dying, that a close relative, a mother, a father, a spouse, a child is dying, that's not, you know, that's not a gift given to everybody. A lot of people have a hard time coming to grips with that. And especially if you engage them in the conversations where they perceive that they are being asked to make the decision to withhold support. If there's any degree of guilt in their background about that, that's going to trigger a real negative response.
well,
So how?
sorry.
No,
Wait,
no, please.
I had a situation actually with my dad, and what was happening to his arteries were old and they were kind of closing down. Not kind of, they were. So I won't name the name of the hospital, so I'm there with him. After the doctor checked him out, he came back to me and said, listen, you have 2 choices. I can make it comfortable, but he's gonna die. I can operate on him, and the chances are he's gonna die on the table. If not, he'll die shortly thereafter. And something said to me, you know what, I don't think you understand my dad. I'm stubborn of a man. Okay? And so I said, you know what, go ahead, you operate. That sent him specifically to me, said, go talk to my son Louis. I have 2 older brothers. No, they go talk to him. So he operated. After about 4 or 5 hours, he comes back and he said, listen, I wanted to put in 11 stents, but I had him open up so long. And at his age, right, that would have been like 86 or something like that at the time. I had to close him up. I could only put in 8, but go spend some time with him because it's going to pass. But he be comfortable with someone. Well, long story short, I took my father out of there 1 week after, about a week after, and he lived for another 7 years. He died at 93. I'm fully conscious when he passed away. Just that the organs were shutting down at 93.
And
So, and I have no medical medical background.
No, but this,
So you see, I'm on both sides of the fence on this one.
no. This is, there, no one can predict with absolute certainty
Absolutely.
what's going to happen. And in terms of surgical interventions in particular, it is a little bit dicier. But the fact is, the stats show that when people are deemed to be in a futile situation, okay, one thing is to operate as a desperation measure, knowing that the risks are against you. That's one thing. But when the likelihood is overwhelming, meaning that there's less than 1% chance of any kind of recovery or any kind of improvement, that's futility. And your situation may be a little bit different. Anyway, so I thought that we were alone in this country because of all our situation. It turns out that we have the same, not the same degree of futile care, but the same problems in addressing end of life in the hospitals in Canada, in Australia, in Great Britain, in continental Europe. They have exactly the same issues. We have studies from Canada and Europe, and one from 6 years ago in Australia, where they did 6 months of review in 3 tertiary hospitals. They have the same type of system as the British system, but they took both ICU and non-ICU patients, and they found that 12% of their patients at some point were receiving care that was deemed futile. And their cost in those 3 hospitals for those 6 months were 12.4 million Australian dollars. So it's not insignificant, the cost of this. And that's something that unhappily society needs to address. So these are the things that set us off, that set this process in motion. First of all, is the lack of patient and family directives. You know, folks who get older, it's always a good idea to say, you know, mom, dad, we know nothing's going to happen soon. We hope nothing happens for many years, but would you like, in the event you have a stroke and are going to be incapacitated, or would you like to be kept alive if you can't talk or you can't walk or anything like that? Just give me an idea of what you'd like to do. And because that's a decision for people to make when they are in their right mind and when they're relatively healthy. If you tell someone who's gasping for breath, hey, would you like me to intubate you? Otherwise, you're going to die in half an hour. What you going to say? That's not the right time. A lot of times people come into the hospital, and despite having chronic illnesses for many years, having been hospitalized multiple times, they have not addressed this in any satisfactory way. And if they say, look, I want to be kept alive at all costs, okay, well, whatever, but at least the decision is made ahead of time and it's been addressed and been talked about. The other thing that probably limits us being able to get a handle on this almost as much is the fact that people, especially older people, can go from being relatively functional to being extremely sick in very short period of time, within hours or days. So the family, is taken aback and said, what do you mean he's going to die? We were just at the party, last week at my daughter's 16-year-old party. He was fine. So that kind of dramatic change makes it difficult for patients' families to understand that. And that's something that clinicians and even people in ethics committees and all can help focus family members on that and say, but this is exactly what happens to people. We go from being fine to having a stroke, having a heart attack, having a major internal bleed, and then we are at risk of dying within hours or days. These things happen. But that's hard for a family to comprehend sometimes, how dramatically someone can get sick. Down the line, but still important, is the fact that people often have unrealistic expectations. I perceive anyway, personally, that there's a lot of that in play when folks are told that someone's had a stroke or had a heart attack or had something bad happen to them. Not all diseases are reversible. Not all acute diseases can be, made to go away. Their effects cannot be negated or nullified. And many times the consequences are devastating. And that's a hard thing for people to understand and to accept. Less likely, but still possible, and we see this, are secondary gain. If you work in hospital settings at all and are involved in ethics committees or palliative care committees, you will sometimes run across situations where there's no reasonable reason, there's no legitimate, obvious reason that a family member would subject a relative to the kind of stuff they're going through when we know the outcome is going to be bad, except for some secondary gain. There's either some secondary financial gain or secondary psychological issues involved at play here. And sometimes it becomes very obvious. Yes, sir.
Doctor, this fertility cases are definitely very complex ethical dilemmas, right? And like reading, I see that probably family member surrogates and physicians, especially family members that were the physicians, they can see them as antagonic.
Mm-hmm.
And I've been doing my internship at Mercy Hospital under pastoral care, and I find very fascinating the role that pastoral care and ethics committee play here as a reconciling body. How they can make these fertility cases and many other so easily going by being a bridge between physicians and surrogates.
Absolutely. How long have you been at Mercy?
For almost a year already.
Okay. So you were there when Father Seguir was there?
Yes.
Okay. So Father Seguir, I work at Mercy, as you probably know. Father Seguir was undoubtedly the most able person at intervening. And if you saw him in action, you would, that's exactly how this should work, because he was able to get people to understand things. We doctors as a rule do not a great job at communicating, and especially in the ICU setting where there isn't one doctor there 100% of the time. We do shift work, so the day doctor may be different. We may have 3 different day doctors in a week, for example. It's a little easier to be kind of standoffish and not be as engaged with family members, and that contributes, no doubt, to the inability to get across the message. Plus, family members, as you say, view us sometimes as antagonistic. The first time you mention withholding or withdrawing support, automatically you are the enemy. So it is a dicey thing. At the same time, establishing a working relationship with a family is key. And if you can't get that early on, oftentimes you can't get it at all. And a lot depends on the family. It depends. Everything has to be enmeshed, because these decisions usually are consensus decisions. We're not going to withhold life support from someone if the family is very opposed to that, even though we think it's not correct. So that's good. So if you saw Father Seguir in action, he was we miss him greatly.
I had the opportunity to shadow him several occasions, and I was amazed.
He's
his
fantastic.
Knowledge and his approach, his pastoral abilities.
Father Seguir was unique. I mean, we've had some very good pastors there, some very good people involved, but I've never seen anybody remotely like him. Yeah. So it's true. You're absolutely right. If you're dealing with that, this is the bear in mind. I put these sort of in order of in frequency based on just my perception, and there's no statistics, there's no reference for this. It's just once in a blue moon we'll have the doctors can't agree as to what's appropriate. We just, some people say, well, push on it and you get better. This is very common with oncological patients. Oncologists, if you talk to non-oncology doctors, and I'm one of them, you'll get the idea that we think that oncologists are not realistic in their expectations either. If you talk to oncologists, they said, well, a 20% chance of survival isn't so bad. I go, okay. So that happens sometimes, but usually with oncological patients. And once in a blue moon, just the families are so obviously difficult that we know that we're going to go to either court or almost as bad as to get denounced to the regulatory agency. By the way, you should know that most states, and the state of Florida is one, if anybody sends a letter to the Department of, now it's the Department of Medicine. The Department of Medicine is responsible for overseeing doctors' behavior and licensure and all that in Florida. A patient's relative sends a letter of complaint to the Department of Medicine. By law, they are obligated to investigate it thoroughly and to provide a report as to what they think happened. So they have to do due diligence, they have to investigate, they have to interview the people involved, the complaining person, the doctor, and this and that. If you have a complaint filed against you and you're a clinician, you have to defend it as if you were accused of something, because you basically are being accused of something. And that is usually anywhere from a 1 to 3 day process of putting together the paperwork. Sometimes involves getting a lawyer involved. It is a nightmare. Even if it's not a civil case, this is not a law suit, mind you. This is not, you're not being sued in civil court. You're being investigated under administrative law. And in that case, the Department of Medicine is judge and jury and executioner all rolled into one. So a Department of Medicine investigation is dreaded by doctors. You should know this. I've been investigated twice, and not pleasant experiences. And so we tend, that's one of the reasons that we tend to avoid situations where already there's a lot of conflict. Family members are unrealistic and very difficult. So it's hard just getting a handle on it, much less doing anything effective for the patient's well-being. We have several cases in the ICU at Mercy now. And one lady that's been on a ventilator for more than a year at 3 different facilities. She's been at Mercy in our ICU since July. Never come off a ventilator. Can't get the son to understand. The husband doesn't understand. No one understands. And they're just dug in their heels. So that's going to, the hospital's taking that to court, actually. Okay, so these are the things that the tools that we have. Advanced directives from either the state or from adult living facilities, nursing homes, and hospitals. Nowadays, by law, they are all required to get an advanced directive from a family member or the patient. If you go to a skilled nursing facility or nursing home, you have to say, I want everything done, or I don't want everything done. You have to designate that. That's been a great help because it at least focuses people on that situation. When you go into the hospital, same thing. You have to say, do I want everything done or do I not want everything? If you don't say anything, by default, you get everything done. So there's already a pathway there.
Same thing with DNR.
Right.
All DNR, they have to.
Right, that's what I'm talking about. When I say advanced directive, I mean, what does the person want if they have a cardiac arrest or respiratory arrest? If it looks like they're going to die imminently, do they want to be on artificial support? By law, that has to be addressed at any, when you go into a nursing home, when you go into an assisted living facility, when you go into the hospital. Nowadays, it used not to be that way. In the 1980s, it was nothing. You had nothing. You had no directive. The next line is really right from the start. If you can engage the family, whoever the proxy or surrogate is, whoever the legal guardian is, in the case of incompetence or disability, you can engage them quickly, early on, not necessarily asking for a decision, but laying the groundwork for what might be expected. You know, your father's here, he's had a major heart attack, his heart is failing, he's on medications, we're going to do certain things. He doesn't look like he can tolerate any kind of surgical intervention, but these are the things we could do. His chances right now don't look real good. We will talk about, you know, what can be done, but you need to bear in mind that this may not play out well. And in that case, do you think he would like to be, you know, his last days kept on a breathing machine? That kind of thing. So at least lay the groundwork for the family to understand where we're at, as opposed to saying, If you arrest, you want him on a breathing machine. If the alternative is to let him die, who's going to say, no, I don't want him on a breathing machine? You know, it's how the things are phrased, how they're understood is a big deal. So if you're involved in that at all, helping the family understand where things might go is really key in getting them to participate meaningfully, because it's if you focus on the well-being of the person involved, that I think helps a lot diffuse a lot of the issues. And then last but not least, certainly not least, our ethics committee, Mercy, has just put together a palliative care program, which I hope will supplement its ethics committee work. We've had a really strong ethics committee, and I would say about half the time their participation has been meaningful and important in getting decisions that are correct for the patients that we were not able to do as physicians or clinicians. And that's I think the last slide in the program, unless someone has, let me see. I'm sorry, please excuse me. I had two cases. And these are actually, both of these are in the unit right now. The ages are different. So let's look at the first one. This is a 73-year-old man, previously healthy and fully functional, was working. Begins to cough, goes to the doctor. Doctor says, you have pneumonia, take this antibiotic. He takes the antibiotic, still coughing a week later, not doing well, feeling kind of yucky. Goes to another doctor says, you have pneumonia, take this antibiotic, and so forth. So he goes along for about 2 months, coughing, never quite getting well, a little bit better, never quite getting well, starts to lose weight, this and that. Finally gets to the point that he's getting really, really short of breath. And when he gets to the emergency room, the man is in distress, serious distress. He can't breathe well, and it seems that he's had an acute heart attack. He is in cardiac failure, he's in respiratory failure, and immediately gets put on a breathing machine. So this man, who was fine 2 months ago, has been deteriorating with what appeared to be a pneumonia for a couple months, but it got to the point that he was just on fire, and by the time he gets in, he's had an acute MI apparently recently. So in the course of the workup, it's found that air's not getting to half of his left lung, and that's because he has a tumor blocking part of the left lung. And that was what was mimicking a pneumonia. He actually had an obstruction in a major airway, so half of his left lung wasn't getting air, was getting infection behind it, wasn't getting well because it wasn't a simple pneumonia. And that's probably the underlying problem. Unhappily, because of all the other issues in the first few days of the hospitalization, in addition to the heart attack that he suffered around the time he came into the hospital, the man develops blood clots in his legs. One breaks off, goes to his lungs, and he almost dies. So the man is now really desperately, desperately ill. He has a procedure that removes most of the clots from the lung, from his good lung actually, from his right lung. But, and he's actually well enough to come off the ventilator, but now we have a man who's had a big heart attack, who has lung cancer that is probably inoperable, who's debilitated, and whose heart has already been damaged by a heart attack. So his outlook, all things considered, is not, I wouldn't necessarily consider him terminally ill, but he is not in good shape.
So it's not in stage.
Well, the problem is we don't know nowadays. Nowadays, lung cancer is a little different animal. 5 years ago, I would say this man probably, no matter what you do, he's not going to do well, unless he's extraordinarily lucky and responds extraordinarily well to chemotherapy. Nowadays, there are for certain types of lung cancer, there are certain types of medicines that are unbelievably effective in controlling the disease. The problem is they're very expensive. Some of them are oral pills. A lot of times they cannot be given to people as inpatients because they're too unstable. And it's going to take a week and a half to get the results of the testing back, because there are special molecular tests that are done to see if the person has a specific mutation that's amenable to a specific medication. So this is a very first, it's an unusual situation, because this man was not chronically ill. He was fine until 2 months ago. He's had a lung cancer for months and months, hasn't known it, hasn't been symptomatic, when it comes to medical attention, he's already got major problems, and unfortunately has 2 catastrophic events, one only partially reversible, which is the heart attack. The blood clots, they will dissolve with time, and they were removed mostly, so he's out of the woods from them. But he's got a lung cancer that is already very advanced. It's blocking a major airway, and this is a difficult situation. None of these have right answers, by the way. There's no right answer here.
So the prognosis will be,
I think the prognosis, all right, so about, let's just do the stats. The stats are that he has about a 30% chance of having one of those special mutations that is treatable. Okay, so is it reasonable, should he have respiratory failure again, and as he is likely to, because his heart is not good, and his heart may cause his breathing to fail again, it may be reasonable to put him back on a ventilator again, waiting for these lab tests to come back, and depending upon what they come back as, decide whether he's a candidate for those treatments or for standard chemotherapy. Chemotherapy given to an acutely ill person like this is likely to kill them.
it'll be a few kill.
Maybe, I mean, he may survive it, but he's a very sick man.
The whole body's in heart.
It's pretty bad. The heart, not as, he's lost about a third of his heart function. By itself, the heart would not be, if it were the only thing present, the cardiac situation might be an impediment to a lot of physical activity, but it would not incapacitate him severely by itself.
But the lung and the heart are tied together.
Yeah, well, I mean,
So we have an issue here.
we have an issue.
Do you think that recommending palliative care, obtaining DNR families would be the best?
I think it's a reasonable thing to do, but since the man was fully functional, this is a situation, he has only one condition that is not curable. This is an incurable lung cancer, but it may be treatable and it may be controllable. More when big airways are occluded by tumors, they almost never can be opened up. So the damage has been too great. And he has a lot of tumor. He has a huge tumor load. Personally, I would like to make it clear to the family that after much struggle and much torment, this man is likely to die, no matter what we do. But there is a very modest chance that he may be able to overcome, get off of, be strong enough to like walk and talk and do stuff again, even though his cancer is incurable, and it may be controllable, and he may be able to get back to some degree of function. So it's not totally unreasonable to push on this man and do everything possible to keep him alive until we see definitively that things are going the wrong way. Not unreasonable. 73 nowadays is not old. When I was 10 years old, a 73-year-old person was like an ancient human being. I know, I remember. You're old enough to remember this, right?
That's complicated.
Right. Well, but I'm saying, but when I remember my parents and grandparents talking about so-and-so died, he was 70, he was 75. Oh, he was 75. Oh, he was really old. I remember that. I didn't make that up. I was 10 years old. I heard that conversation. Now 75 is nothing.
I was 93 and my mom was 86.
Yeah, we're at least 10 or 20 years out of phase with what was the case when I was a young man. Okay, anyway, so the next case is maybe a little bit more straightforward. This is a 69-year-old man, a younger man, who's morbidly obese. This man is about 120 pounds above his ideal body weight. He has chronic obstructive lung disease. He has COPD. He's been a heavy smoker for much of his adult life. He's diabetic. He does not take his medications usually with any regularity, nor does he follow up with doctors with any regularity. And he has had 5 prior hospitalizations at Mercy this year alone, all of them for respiratory failure, because the man has, in addition to being way overweight, he's got really bad airways and lungs. He has no family members. He lives by himself. Now he presents with respiratory failure and requires a ventilator for the first time. He is now so sick that he can't breathe on his own. After 5 days of ventilator treatment, he's able to come off the ventilator, but clearly he's at risk for further events. What should be done? Because now the man is recovering from his respiratory failure, but this is 6 hospitalizations in 11 months. And when you see that pattern in general in medicine, when you see somebody back in the hospital, either they have a very simple disease that they just are very bad at taking care of, or they have a more difficult disease and they're not taking care of it, or they're just at the end of the road, or some combination thereof. And this man has that combination. He doesn't take his medicines. He doesn't follow up his doctors. He goes to the hospital. They tune him up enough to get him functional, to live by himself again. He goes home, and he's smoking, and he's not taking his medicines. And sooner or later, a month or two later, he gets bad enough again to get back in the hospital. This time, he got worse than ever, and he ended up on a breathing machine. So first, what's likely to happen to this man? We'll get him out of the unit. We'll get him out of the hospital. What's going to happen to this man?
Come back again.
He's going to come back again.
And every time he comes back, it's going to be worse.
Eventually, when he comes back one time, he won't leave.
We won't get him off the ventilator. So what's appropriate here?
Since he doesn't have a family, probably assign a social worker as a proxy.
I think that's a good idea. That this would be a case that before he leaves the hospital this time, the state should be approached to assign a social worker as a surrogate and make decisions for this man. And if he cannot go to a supervised, this man needs to be in a supervised facility. He needs to be somewhere where he can't smoke and where he is made to take his medicine. If he were there, he probably wouldn't be in the situation. So it's a little bit more straightforward, I think, as to what's best for him in terms of trying to keep him from getting sick all the time. Okay, so that was it. I think that is it. The last slide should be blank. It is blank. Do y'all have any questions about anything we've talked about, or any specific issues or things that we haven't talked about that is on your mind?
Extremely informative.
Yes, very
Okay. Oh, well, thank you.
I visit the hospital so much, and you never know what's going on behind the so-called closed doors.
Okay. All right.
It's
Well, if you're ever at Mercy Hospital, you can find us. We have 2 ICUs that we go to. We don't go to the neonatal ICU, but the 2 adult ICUs we go to. You'll find the team. I'm usually rounding Monday through Friday with the team between 8 o'clock and 10 o'clock in the morning. So we'll be in one of the 2 units sometime then. Have I seen you there?
I don't recall.
Because if you've been there, I'd say I'm usually walking in the halls every morning.
We're gonna continue going because they
But you're not there every day.
not every day, no.
Okay.
But on a weekly basis, yes. My wife is also a member of the ethics committee, and she goes there twice a week.
Okay. Okay.
Doctor, you did introduce yourself at the beginning. Would you like
I'm
to
sorry. Please.
provide
I do apologize, and it's true. My name is Raul Moas. I'm a physician in practice at Mercy. I've been at Mercy way too long. I've been at Mercy since 1985. And I've been medical director of the ICU for about 15 years, give or take. Yep.
You still a pulmonologist? Do you have like a?
And my original training is in lung disease. I'm a pulmonologist by training. Yeah. But I've been out of actually private practice. I left private practice in the beginning of September to do more full-time work. And I'm actually, in January, I'm starting teaching medical students from FIU. They're going to be rotating at Mercy for the first time ever. Yeah, so I'm looking forward to that.
How do you spell that?
M-O-A-S. M as in Mary, O-A-S.
M-O.
O-A-S, Moas. Yeah. First name is Raul. Okay. Well, great. Well, thank you. Thank you, Father, in St. Petersburg. Do you have any questions, sir? Are you still there? Father may not be there. Okay.
No, he probably still is, but he just
Okay.
Start the recording then.
Shall I just X out of here, or do I need to
Let
do
me
something
stop the
special?
recording first. That way I save it to the computer